This is the okay. Start again. Hello, everyone. This is the Antiretroviral for Prevention Science Working Group, the InterCFAR group, that is co-moderated by my colleague, Dr. Patrick Sullivan of Emory University. And I'm Ken Mayer of the Harvard University CFAR and Fenway Health. We have a very exciting speaker with us today, Dr. Dawn Smith, but we'll wait another minute or two just to get our quorum. Our format today will be that Dr. Smith will be giving her talk, and Dr. Sullivan and I will be monitoring the questions, and Dr. Sullivan will be facilitating a Q&A at the end of Dr. Smith's presentation. So please send in your questions so we can have a nice, robust discussion of this very interesting data. We'll give it another minute, and thanks folks for attending. We often have people who join a minute or two late. So my understanding is the joy of Zoom protocols are the 3-minute window. Getting on that. So I want to thank everybody for attending today. We're really fortunate to have with us Dr. Dawn K. Smith. She's the Clinical Biomedical Prevention Activity Lead in the HIV Research Branch of the Division of HIV Prevention at the U.S. Centers for Disease Control and Prevention. Dawn has been the point person overseeing implementation of the use of antiretrovirals for prevention. She's led initiatives to develop and harmonize guidelines on post-exposure prophylaxis and has been devoting a substantial amount of her time over the past decade around issues related to PrEP implementation. She's been previously the Associate Director for HIV Research at the CDC Field Station in Botswana. She's been a member of numerous committees for various federal agencies and international bodies as well. She's trained in family medicine, receiving her MD from the University of Massachusetts. She has an MPH in Public Health Policy and International Health, and a Master's in Clinical Research Design and Statistical Analysis from the University of Michigan. And we're very fortunate to have Dawn in the role that she plays, and very fortunate to have her here with us today. So without further ado, Dawn, please take it away.
Good morning, everybody. I'm really excited to be invited by two of my favorite long-term colleagues. Dr. Mayer was one of my first mentors when I came to CDC, and we started working on an HIV project together. And Patrick has been a key partner in all of our PrEP activities. So it's this July, it'll be 10 years since the FDA approved Truvada for PrEP. And the last 10 years have been very busy for everyone in this field, trying to roll out and scale up PrEP use in the United States. And while we've had some success, we're not where we wanted to be and not where we should be. And so we really have to step up our game for the next 10 years, both CDC and our community partners. Let's see. Oh. So, as you know, CDC is a key partner in the HHS initiative to end HIV, the HIV epidemic, also known as EHE. And in that effort, there are 4 key strategies: diagnosing everyone who has HIV as early as possible so that they can be started on treatment, both to protect their own health, but also to reduce transmission to others. To treat people with HIV so that they achieve viral suppression and U equals U status. The prevent pillar is designed to prevent new HIV transmissions, and especially focuses on expansion of both pre-exposure prophylaxis and syringe service programs. And then the last pillar has to do with response to clusters and outbreaks, and getting people, getting those identified and getting the needed prevention and treatment services in place as soon as possible. As CDC is thinking, as the Division of HIV/AIDS Prevention is thinking about how to accelerate PrEP in particular, we've started by thinking about which are the groups of people who have the most new diagnoses. The goal for the EHE initiative overall is to reduce the number of new HIV infections by 75% by 2025 and by 90% by 2030. And key to that is being sure that our interventions are targeted where the most new diagnoses are occurring. This looks at HIV incidence by age, and you can see that in the youngest age group, we've actually had some success. In the last few years, there's been a lot of effort put into demonstration projects and activities to try to address the HIV prevention needs of this young adolescent and young adult population. And that seems to be working. On the other hand, we're not doing well with the next age group of adults aged 25 to 34, where HIV incidence has actually increased over the last several years. If we look by transmission risk category, we can see that it's still largely an epidemic in which 2/3 of the new cases are occurring among persons who have male-to-male sexual contact. But about 16% are occurring in heterosexual females and another 7% in heterosexual males. And then injection drug use takes up the remaining 10% of new HIV diagnoses. If we take that incidence and use it to determine what's the lifetime risk of acquiring HIV infection in persons who are uninfected at age 18, you can see that for African American men, that risk is 1 in 20, and for African American women and Hispanic men, it's 1 in 48, with lower lifetime risks for Hispanic women, white men, and white women. I'll come back to this, but it is important that in almost every category we look at, African Americans have an excess risk. The one exception is among IDU, where their risk is approximately the same as white persons. If you look among MSM, African American MSM have a 1 in 2 lifetime risk of an HIV diagnosis. Hispanic MSM 1 in 4, and white MSM 1 in 11. Now, this assumes that we are not successful in scaling up prevention and including PrEP. And hopefully we will do a good enough job that these numbers will not be reality going forward. So then if we start looking at, well, how are we doing with PrEP with respect to race, ethnicity, and sex? What you can see is that there is a significant disparity already 10 years in to the epidemic. And you can see that in the yellow are the proportion of persons with indications for PrEP use, condomless sex, STI in the last 6 months, those kinds of things. The green is a proportion of persons taking prescribed PrEP who fall into that group. So you can see that in 2018, while 42% of those with indications were white, only 29%, they accounted for 29% of no, I did it backwards. Although whites constitute 29% of those with indications, they were 42% of those who received PrEP. And you can see that for African Americans, while they were 40% of those with indications were African American, only 5.9% of those who had indications received PrEP in that year. There's a similar disparity when we look at sex at birth, where the overwhelming proportion of PrEP prescriptions are to men, and women are much underrepresented in terms of their access and use to PrEP. This is another way of looking at it from the AHEAD dashboard, which monitors indicators for the Ending the HIV/AIDS initiative. And what you can see here is that the disparities are getting worse, not better. So if you look by gender on the left, or by sex on the left, rates are increasing rapidly for men. They are not increasing as rapidly for women. In the data sets that's used for this, which is a pharmacy data set, we don't have transmission risk group, but it is our presumption that the majority of the men who are getting PrEP prescriptions are in fact MSM. On the right, you can see PrEP coverage by race ethnicity. And again, you can see that for whites, the rates are increasing much faster than for every other race ethnicity. This is particularly discouraging because models suggest that in order to reduce the Black-white disparities in HIV incidence in new infections, you would need to have even higher rates of PrEP use among African Americans than among whites. And so in this agent-based model of HIV transmission for MSM, looking over a 10-year period of time, the model looked at initiation of PrEP, adherence to PrEP, and retention in PrEP, and varied them to try to see what the impact on incidence would be. And based on studies in Atlanta and some other open label studies, the 10-year incidence for Black MSM was 7.7 per 100 person years, and for white MSM was 1.6 per 100 person years. When they applied the race-specific values of initiation of PrEP, adherence to PrEP, and retention in PrEP that were seen in these studies, you can see that there was a modest reduction in incidence for Black MSM. There was there was a marked reduction, a halving of incidence for white MSM. They then systematically looked at setting the values for Black MSM in relation to the values that were observed for white MSM in a different way. So if you assign to Black MSM the same values that were seen for white MSM, you got another small reduction in HIV incidence. But if you look at the last row, if you gave Black MSM twice the rates of initiation, adherence, and retention that were observed in white MSM, you still had a 1.7 incidence rate, which was the same as the no PrEP incidence rate for white MSM. So in order to get enough PrEP on board with the Black MSM community to reduce HIV incidence, we would need more than double what the amount is in the most advantaged group of white MSM. This kind of disparity was sort of expected. It's a common story. when you look at health equity issues in all kinds of healthcare. And in particular, if you go back to the HCSA study, which was looking at a national probability sample of persons receiving antiretroviral therapy at the time when HAART was first being introduced. Rand did an interesting analysis where they had collected all these different social, what we would now call social determinants of health. And they did a sequential model where they tried to account for each of those determinants and see how much disparity remained. And what they concluded at the end was that even after controlling for all of the other variables in the model, the odds that African Americans were receiving early HAART was less than half that as whites. So I think we knew that we were going to have a disparities problem. I think we hoped that because we knew that we were going to be able to address it, but we haven't done a good job yet. So what about providers? One of the things that was evident early on was that CDC was going to have to do support a fair amount of work to try to get primary care clinicians aware of PrEP and prescribing PrEP. This was because patients who are candidates for PrEP are not usually seen in an infectious disease clinic where HIV providers are. They're seen in primary care settings. And so we really thought that it was important to try to get primary care doctors on board with PrEP. This is what happened when we looked over several years with a national sample of primary care physicians called DocStyles. And what you can see is that there has been a steady increase in the proportion of primary care clinicians who are aware of PrEP, and a much slower increase in the number who have actually prescribed PrEP. And in 2020, there were approximately 15% of providers who had ever prescribed PrEP. A more recent analysis used the prescription data to look at the number of PrEP prescribers in the United States. And on the left, you see their distribution and number in 2014 and in 2019. And you can see that the distribution of providers has increased significantly, but that they are concentrated in specific metropolitan service areas. In 2019, there were about 66,000 PrEP prescribers, which was an increase from 9,600 in 2014. About 60% of the prescribers were physicians, and about 30% were nurse practitioners or physician's assistants. When the number of prescribers in this database were compared to the number of active prescribers in some health services databases, about 4% of all prescribers had prescribed at least one PrEP prescription. That was 13% of family practitioners and 34% of ID MDs. However, about 50% of PrEP patients who were prescribed PrEP were prescribed it by about 2% of PrEP prescribers. So there are a small cadre of PrEP providers who are doing the bulk of the work, and we have not successfully disseminated it more broadly among primary care prescribers. One of the things that the EHE initiative is helping with is introducing the Bureau of Primary Health Care in HRSA is funding many of its federally qualified health centers to prescribe PrEP by funding physician positions that are dedicated to the provision of PrEP. So one of the things that we have tried to understand is how do we talk to clinicians about including PrEP as one of their prevention services. And there's this nice framework that has been developed for use in understanding how clinicians decide which of the many prevention practices that are recommended to them that they want to include in their practices. And it includes a variety of things that we have not yet adequately studied in the area of PrEP. So providers want to know whether they should address lifestyle factors like sexual behavior. Is this something that they think is their role? And do they really think that they can make a difference if they try to address these lifestyle factors? If they decide that this is something that they should do, then they need to understand, well, how exactly can they do it? Do they feel effective to do it? Is it something that their clinic system is going to be accepting of their doing, and are they going to get the support they need from their system to do that? And then if they decide they can do it, then they have to decide how they're going to do it. And so this is where many of our academic detailing or public health detailing operations around PrEP have focused on sort of talking providers through what role they will take in providing PrEP, whether they're going to use a team-based approach or whether they're going to be primarily responsible, what are the risk management practices that they want to include in their provision of PrEP, and what are the intervention strategies that they're going to choose. Much of the work that's been done in trying to roll out PrEP has been done with patient populations, and very little has been done to try to understand what are the barriers and facilitators for clinicians to actually engage in PrEP, particularly primary care practitioners. And this is something that CDC is spending more of its time doing in the coming years. One of the things we've learned is that providers sometimes need to be convinced that it's really something that's worth the effort for them to do. Busy primary care practitioners have many prevention interventions that they're expected to be implementing with their patients. And so we've looked at what are the ways to kind of embed PrEP into the context of all the things that they're already doing for prevention. So this was on the left was a nice analysis that looked at the number who were needed to treat to prevent the outcome of interest. And what you can see is that in the kind of burgundy color, you only needed to treat 14 MSM to prevent a PrEP infection within 3 years. These are the kinds of things, this is less number needed to treat, and particularly for Black MSM, than is needed for provision of statins, ACE inhibitors, or metformin, all things which primary care practitioners do on a regular basis. The other example that we've sometimes given people has to do with missed opportunities. If a provider has a patient come in and test HIV positive, and you can demonstrate to them that they had opportunities to prevent that infection from occurring, it's a motivator for them to adopt PrEP as a part of their primary care. And there are a number of studies showing in New York City, in South Carolina, in the Veterans Administration, in Alabama, that identifying people who have a prior negative test and who were not offered PrEP, but who went on to develop HIV infection is a fairly common occurrence. And in the VA in particular, it was a difficult finding that 35% of those with indications experienced delays in receiving PrEP that ranged from 6 weeks to 16 months in a system where the cost of the medication and the cost of the care is not a problem. And in fact, some patients did become infected during those intervals. One of the obvious places to go is patients who are partners or sexual contacts of persons who have syphilis or gonorrhea or HIV. And this is particularly useful for women. This is an example of a study that was done with a transmission network that started with Black MSM and looked at the partners who were identified during partner services follow-up. And the red circles are nodes within this network of Black MSM that have at least 2 uninfected women. And so although we tend to think that these populations are separate, they are increasingly recognized as interrelated, particularly in the Black community. And this is an important way to identify women who are at especially high risk of HIV and who would benefit from PrEP. Several studies have shown that one of the major problems we have from the patient perspective is that too few patients who would benefit from PrEP are aware of it. They don't know it exists. They don't know what it is. And so they're not asking for it or necessarily receptive to hearing about it because it seems new and novel and a bit strange. If we look at the national HIV behavioral surveillance system, there's a couple of important things to notice. Number one is in 2017, the year of the last wave in MSM, there were fairly high rates of awareness of PrEP among these MSM, but fairly low rates of PrEP use. The other thing that's important to notice is that a minority of these men had received any group or individual intervention in the previous year. One of the ways that we have tried to support increased awareness of PrEP is to fund community-based organizations to do education, intervention, HIV testing, et cetera, with the populations who would benefit from PrEP. But one of the things that has become really clear is that a large portion of particularly the Black population, the Black MSM population, is not receiving services from these CBOs. So the reach of the organizations is not sufficient to cause widespread awareness of PrEP. You can see that among IDU in 2018, awareness of PrEP was pretty low and use was even lower. And among heterosexuals, it was low as well. So we have a lot of work to do in order to get awareness of PrEP where it needs to be. And we also have data, particularly for Black MSM, but also for other populations, that the NHBS sample, which is in some ways designed to find higher risk people and people who are more connected with community-based organizations and health departments, yields higher levels of awareness than population-based samples. So in the 2016 National Survey of HIV in the Black community, only 15% of Black adults were aware of PrEP. And of those who were at high risk by reported behaviors, only 20% were aware of PrEP. 52% of the MSM in the sample of Black MSM were aware of PrEP. So it's part of, we've had some success because we focused on PrEP for MSM in getting the message to MSM. However, willingness to use PrEP, again, was fairly low in this sample. Only a quarter of adults, only a third of those who were at high risk, and less than half of those who were MSM. One of the things that we've thought about in terms of initiation is there's a lot of discussion in the field now about two new ways of delivering PrEP. One is pharmacy-based PrEP and the other is telehealth. I was surprised to learn that there are things called pharmacy deserts. And so as we think about putting PrEP in pharmacies, often this is done in pharmacies that are in neighborhoods that have high concentrations of MSM, and often in neighborhoods that are relatively more advantaged than others. In talking with some of the leadership, for example, at Walgreens, about where they place their clinics that operate in pharmacies, they acknowledged that they are not often placed in disadvantaged neighborhoods. So here you look at Chicago, and on the right you have where the African American population lives, and on the left you have where the pharmacy desert occurs. And you can see that there's a pretty significant correlation between the two. So while putting PrEP into pharmacies may help in access and initiation for some parts of the population, they may not do as much for the populations experiencing disparities. Another thing that has been tried to try to help initiation of PrEP has been to reduce the cost involved in PrEP. So the U.S. Preventive Services Task Force gave it a grade A recommendation, which means under the Affordable Care Act that insurers have to provide PrEP without cost sharing. And in July of this year, the Center for Medicaid and Medicare Services issued a clarification that PrEP clinical services included the laboratory testing, the behavioral services, and the clinical services that are part of PrEP, not just the medication. Unfortunately, these regulations have holes in them. They don't apply to all types of insurance. And so there are proposals in Congress now to pass legislation to make PrEP without cost sharing for all who need it. Telehealth is another thing that has been very important during the COVID-19 lockdowns to maintain PrEP services for those who are already on it, but also to allow us to expand PrEP delivery. However, again, there are studies showing that telehealth doesn't reach all the populations equally. And so patients were less likely to use video visits, for example, if they were Black or Hispanic, if they were older, if they were Spanish speaking, or from areas with low broadband access. And similarly, in another study, patients attended fewer telemedicine visits if they were female, non-English speaking, older, or of lower income. So as we expand telehealth, we're going to have to be very careful that we're not counting on it without intervention to reduce disparities. One of the early things that we worried about was adherence. And I think in the last few years, we've learned that persistence on PrEP is as important, if not more important, than adherence. So in one recent study where they looked at persistent use of PrEP in Medicaid patients, you can see that overall, by 3 months, 21% of patients had stopped their PrEP. By 6 months, half had, and by 12 months, 2/3 had. And there was a median persistence of about 7 months on PrEP. There were differences by gender and by race, where women were less likely to persist on PrEP over the long term. And Black patients were less likely to persist than other race patients. This is important because of several studies. This is a more recent one from California, where they looked in the Kaiser system and they looked at patients who were linked to PrEP, but were not prescribed it for some reason. And they had an annual incidence of nearly 1%. Those who were prescribed PrEP but didn't take the PrEP, never picked up their prescriptions, similarly had an incidence of about 1%. Those who stopped and did not restart had a slightly higher incidence of 1.28. Those who stopped and then restarted had a very low incidence, and those who persisted on PrEP had essentially a 0 incidence. So illustrating the importance of two things. One, keeping people on PrEP for the duration of their period of risk. And the second thing is when people stop, encouraging them to restart if they still have need of PrEP. And there are other studies showing that actually stopping and restarting is a very common process. And we need to support patients through that process rather than considering them lost to follow-up, for example. So the other question people ask is, well, why are you spending so much time on PrEP when U equals U? Shouldn't you be spending all your time on treatment and getting people virally suppressed? Then you wouldn't need PrEP. Well, first of all, we are not where we need to be with viral suppression in this country. So the goal is 95% viral suppressed by 2025 and 2030. Right now, we're at about 56% virally suppressed. That viral suppression that's measured in that previous chart is persons who at the most recent visit in a year were virally suppressed. But we've also looked at analyses about how many people have sustained viral suppression. So at each visit in a year, they were virally suppressed. And in this calculation, they looked at what was the transmission risk potential based on the mean number of days with a viral load above 1,500 copies. And what you can see in the overall column is that overall 56% of 56% of the entire population, 56% of the days in the entire population were spent with viral loads above 1,500. And you can see that by race ethnicity, the rates were slightly higher for Blacks than they were for other races, even looking at age and sex. One of the things that was interesting was that for the youngest people, spent the least time with viral load above 1,500. And the thought is that these younger persons are probably benefiting from support from parents and others to be more adherent to their medications. But given this finding, it's very clear that we are not where we need to be in order to count on treatment and viral suppression as our only method for reducing HIV incidence. And in fact, if you look at Botswana, where they have universal free antiretroviral treatment and have had it for a very long period of time, they have about 95% of their population who are HIV infected virally suppressed. Of those who are in treatment are virally suppressed. However, they still have 9,500 new infections a year, and to almost a quarter of the population with prevalent HIV infection. So even in Botswana, where they have done a great job at getting everybody treated, they are now scaling up pre-exposure prophylaxis. So if we address all these many factors, I think one of the things we've learned over the last 10 years is that this is not just a clinical trial result, that we can actually make a difference in incidence. So if you look at New York State's dashboard, for example, where they've had a very gradual but continuous increase in individuals prescribed PrEP, and it corresponds to a very steady decrease in the number of new HIV infections. Patrick Sullivan and several of us did an analysis where we divided states into quartiles based on their change in PrEP use over the period 2012 to 2016, and then controlling for viral suppression. We were able to look at the relationship of PrEP use to HIV diagnoses. And what you see is that in the two quartiles with the lowest increases in PrEP use, you had slight increases in HIV incidence. And in the two quartiles that had the highest that had the highest PrEP increases, you had the highest decreases in HIV diagnoses. So given all these things, what's next for the Division of HIV/AIDS Prevention? Well, our commitment is that we need to go forward with PrEP, and we need to do it faster. So later this week, we're issuing an updated PrEP clinical practice guideline. And as new approved medications for PrEP come along, we will continue to issue updated guidelines. This new guideline will talk about the use of cabotegravir injections. It will talk about telemedicine and same-day initiation of PrEP. And it will also talk about 211 PrEP, or event-driven PrEP. In accord with the End the HIV Epidemic Initiative and the new National HIV/AIDS Strategy, DHAP will be assisting states with financial coverage issues for and underinsured PrEP patients. In the EHE initiative, we have funding. We have provided jurisdictions some funds to use for these purposes, and we are looking for ways to provide additional funding to help the states help these patients. We will be collaborating across federal agencies to address the social determinants of health. So working with SAMHSA, working with HOPWA, working with NIMH, working with a variety of federal agencies to provide additional aspects of health care and social care to persons who would benefit from it, to increase their adherence and persistent use of pre-exposure prophylaxis. We will be increasing the opportunities to integrate STD, viral hepatitis, and care services for PWID with PrEP. So incorporating PrEP into syringe service programs, incorporating STD and viral hepatitis testing, along with HIV testing in the screening and follow-up of patients who are on PrEP, et cetera. We have funded STD clinics to be PrEP providers, and we will be expanding those services in the years ahead. And then we'll be doing a lot of work to monitor both PrEP delivery and the quality of PrEP care. And because I think we need some better measures in order to be sure that we are approaching the targets that we've set to make PrEP really available and useful to the persons who would benefit most from its use. And we'll be conducting demonstrations and implementation science research to improve PrEP delivery, especially for these priority populations, and especially to reduce disparities in PrEP use. Thank you for the opportunity to share this vision with you, and I look forward to your questions.
Great. Dawn, thank you so much for this, which has been really comprehensive, but also, I'm grateful for the sort of public health orientation to it, both the clinical and the sort of population look at this. And of course, thank you for your leadership through the years, through the early years and through the current years in sort of keeping this both the issues of the need for PrEP and PrEP equity at the forefront of the conversation. So many thanks for the talk and for your leadership in this, through this whole process. We're gonna open up to questions from the audience, and I think I will let Ken kick us off, if that's okay. And others, if you have questions, you can just shoot me a note in the chat that you have a question, or you can raise your hand and I'll keep an eye on that as well. So Ken, over to you.
Thanks, Patrick. And Dawn, thank you for an excellent talk, and sobering in terms of highlighting the disparities. And my question is, you at the end mentioned two modalities, one that's not so new, but relatively new in terms of scaling up in the US, on-demand or 211 PrEP, and then injectable PrEP, which we anticipate will be FDA approved by January 24th coming up. I'm just curious, from your standpoint, do you think that these are likely to exacerbate some of the disparities you called on, or do you see opportunities for them to be game changers and to address some of the disparity concerns that you raised?
The only evidence we have about 211 type dosing in racial and ethnic populations in the US is from the ADAPT study. And there was an arm of that was with MSM in Harlem, Black MSM in Harlem. And unfortunately in that study, coverage of sex acts was less for African-American MSM than for others. And I think we're going to have to monitor closely to see whether this is a form of PrEP use that fits well with people's lives in disadvantaged communities as much as it does with highly educated, highly advantaged communities. It's a fairly complex regimen to understand and to use properly. And I think we're just going to have to see. I don't think we know whether it will make disparities better or worse yet. Cabotegravir, I think I don't see any reason why it would make things better. I think we're going to have the same problems with disparity that we have with oral prep. And it may even be exacerbated by the need to have injections every 2 months instead of a prescription visit every 3 months. And again, I think we don't really know. I mean, I think we do know from the trial that had a sufficient number of Black MSM in it, the 083 trial, that it works well in Black men. But I think we don't know what we're just going to have to watch and see whether people are willing to give it, whether it's affordable, and whether it's actually a preferred option for different populations.
Thank you.
Great. Thanks, Don. I think that there's also will be interesting work as we start to see what those choices are to compare the sort of hypothetical studies that have been done about preferences for these options with what people actually use, and particularly with attention to race and ethnicity.
I think CDC has funded RTI to do a discrete choice experiment that will look at oral prep as well as cabotegravir and some of the other modalities that are on the horizon. And we're going to look both at different populations and of patients and also at providers, different populations of providers. So I think, yes, there'll be a lot of work in the next couple of years to try to understand the hypothetical use of these, and then we'll have a chance to see how that bears out in the actual use.
Yeah, thank you. I'm just going to relay a question from Dr. McKellar, which is, were there any significant changes to the PrEP guidelines since the draft guidelines and webinar?
Yes.
Okay, follow-on question. Anything you can say about that?
We got a lot of comments and they were very helpful. I think the most significant one is probably that we revised the HIV testing algorithms. It used to be one algorithm for everyone. The new guideline will have two algorithms, one for people who have no recent antiretroviral exposure, and that will look very much like the one that's in the current guideline. But there's another one now for people who are currently taking PrEP or have recently taken PrEP, either cabotegravir or oral PrEP, because of the evidence, the increasing evidence that antigen antibody testing will not detect incident HIV infections under the pressure of antiretroviral use. And so the new algorithm will focus more on HIV RNA assays. And that's all I can say about that.
Excellent. Don, I have a question about, you talked about the quality, like needing to look increasingly at the quality of PrEP care going forward. And I just wonder, have you worked on, or is there work being done on those metrics, and what kind of data would be needed to evaluate them? Like, could it be done at a state level or at a practice level, or just any thoughts about how that will happen?
I think it can it can absolutely be done at a practice level, and therefore it can be done in demonstration projects that are operating within clinics. I think we're also interested in looking at electronic medical record databases as a source for some of that work. at least to understand how frequently HIV testing is being done, how frequently creatinines are being measured, how frequently patients are missing visits. Those kind of simple things can be done through electronic medical records. But I do think that there's also a need for studies that are designed to look at this in a very objective way. So, for example, I was very interested in I believe it was in Tennessee during one of our demonstration projects where they did a mystery shopper study to sort of objectively measure what was happening when patients went to clinics, what topics were covered and not covered, what things happened that they perceived to be stigmatized behaviors. And I think there's a lot of room for researchers to take a close look at what's actually happening in the clinics.
Great. So it sounds like a combination of some objective measures of compliance with guidelines and some measures of the experience of people seeking and being on PrEP that would be part of that sort of quality of care. All right, well, we are about at time. I want to let people know that we're going to be on hiatus over the holidays, but we'll be back in February, February 7th, with another installment of the series, and excited that that Bohdan Nosek is going to be presenting on a recent analysis of how the health benefits that arise from preventing HIV infections, attributing health benefits of treatment to preventing new infections and improving health outcomes, and the balance of that among people living with HIV. It's an analysis in 6 US cities and sort of gets at the sort of treatment side of antiretrovirals for prevention. And so that will be on February 7th at this time. You'll get another notice of that. And we appreciate everyone attending today. Appreciate first and foremost, Dawn, for such a thorough and thoughtful and thought-provoking presentation. So thank you. And also our colleagues at Harvard CFAR who help with the production of the webinar, and my co-host, Ken Mayer. So with that, I will thank everyone for coming, wish everybody a good week and a good holiday season, and we look forward to seeing you again in February.
Thank you. Take care.
Bye.
Thank you, Dawn.
Thanks, Don. Bye.
Bye.